Systemization of breastfeeding. So what does that mean? How can breastfeeding be impacted by the systemization of healthcare and its policies, its education, and the support readily available for breastfeeding mothers? Today, I am joined by the very, very lovely Dr. Robyn Thompson, who is here to discuss her idea of the isation syndrome, which we have been discussing in part over the last few weeks. So do check that out. Dr. Robyn, thank you so much, as always, for joining us. So today, this week, we are talking about lactationization. Tell us more.
Lactationization, I think lactationization in the way I had to take all of these isation syndromes practices out of my head and put into a model and then explain the model came about because we have been taught for the past 50 years to what we would say force babies to the breast, right? Someone forces the baby to the breast. And it's part of the education, so it's not a blame game of any sort. It's an education that's gone on for a long, long time, and people still are following that. I've had the most privileged opportunity to review all of that, and that has made I used that a few times, didn't I? That has made my understanding of how important it is not to touch the mother and baby at all, but we work with her and we encourage her. And again, if you did need to touch her, it's only with her consent. It's not just walking in, taking over, and doing all the things that has become lactationized. And that's along with all the other things. Once you're institutionalized, that's another problem. Once you are policyized and politicalized and medicalized, that adds to all the dilemmas. And we've forgotten that, the beautiful mother, it's her baby that's growing and she's transitioning. She's not going through, different things. She's actually transitioning the growth of her baby, which is unique to her and her genetic background, her own biophysiological body with her baby, all of the factors that come into genetics. And then she's transitioning from that into labour and progressive labour the way she's going to do it uniquely. And, the first time mother might do it a bit longer than the second time or third time mother because, all the ligaments have been stretched previously, the pelvis has moved, and generally the second baby, not always, but generally the second baby is born a little bit faster. The fear of breech birth, here's me 79 years ago, born by the breech, feet up there, so sucking my toes. And still I've got the best hamstrings in town.
Defying the norm.
And still there's some beautiful stories coming about now, which is really good. It's almost at the 50-year turnaround. Where women are now challenging all of that and they're making decisions and they're making good decisions and it's been good for them. Now, I'm not saying that's 100% of the time. It's not, can't be. No. We can never guarantee, no professional can guarantee 100% perfect outcome all the time. We do what we need to do at any one moment in time, and that's our medical colleagues, our midwives, nursing when they're working in the nursing field. Of course, midwifery and nursing is separate professions here. Midwifery is a profession in its own right. So we do, we have all of that. And if we have, like we did 50 years ago, buddies that were our obstetricians when we needed them, they didn't interfere. They sat in the background, or they didn't even come until we called them if we needed them. And then, there was this relationship that was always very communicative between GP, midwife and mother. There was none of the things that go on now. So the other problem is insuranceisation. Insurance has divided us all.
Yeah, you've spoken in the recent weeks about the how important it is to have healthy communication between multi-agency within the setting, within the provision of for pregnant women, as well as labour and birthing, and the follow-up as well.
And then
with the
policyisation. Oh no, you have to use our policy. Policy is not a legislation, so they do not have to be coerced by policy. That's because it has to be done their way, not listening to and being with the mother.
And
So,
when I think about the care system and how it provides care for pregnant women and breastfeeding women, I always think about the policies and the procedures that impact this. And I always think of growth charts. I think of the policies around weight gain and the 10%. I think about
it's
the
gone out of
procedure and
hand.
checking for tongue ties as a first maneuver for anyone that's having any experiences with challenges. And I think about all these check boxes that must be ticked off. And of course, a little bit later, we'll discuss those first few hours following birth. But in general, in those first few weeks, there's so much pressure. Why can we not just be assessed as individuals? Like, our babies are unique.
And then there's the next transition to the way a woman gives birth, how she chooses her body to work, how she wants to be, preferably not flat on her back, because that's suppressing her pelvis, not allowing it to open in the way it should. And it's suppressing the sacrum, which means the diameters are changed as well. And it's much more painful for her to be on her back. So then there's that transition then to breastfeeding once her baby's in her arms, and that takes time. It just takes a little bit of time. That's why I've referred to it as the 3 golden hours. Having watched thousands of babies coming to the breast when they're ready, they're not ready straight away, most of them. Some will come in a half an hour, some will come in an hour. Some that are affected by opioids might not come at all. Then you need to hand express gently to provide the colostrum for the baby, the very first gut preparation for the baby.
Yeah, we've discussed colostrum in a recent live video, so if you want to learn more, do let us know. We'll share the link below. Dr. Robyn has the unique perspective of having worked managed and run a labour ward for many years, and her own private midwife practice at home as well. So facilitating home births, and we were talking before, facilitating a lot of first-time experiences for mothers within the hospital as well. So we're going to do a show on that very, very soon, on the experiences that Dr. Robyn had. But today we're talking about your perspective and how you recognise the differences between the two. So coming from the hospital system into home care practice, like you just said, and you thought of these 3 golden hours. Many hospitals talk about 1 golden hour now. Since recently giving birth myself, I can see how rushed that is. 1 hour, as golden as it can be, is not very much at all. That time flies by. 3 hours, however, is much more realistic in giving baby time, giving yourself time, the placenta time, everyone around you time. And you do talk about in your 3 golden hours video, which I will be popping down below for those viewing, the rush of the system, the need to check boxes, as we've already said, the routine examinations. And you say, don't you, Dr. Robyn, that if a baby's APGAR score is 7 or above, and you are perfectly healthy and you're happy to take baby, they belong in your arms to get that process going. So tell us more about why you recognise the importance of the 3
with respect to the 1 hour, that was in the research some time ago, and that started to change the approach to understanding that the baby will find its way to the breast, and the baby can do that because the newborn healthy baby is wanting to survive. So it's making its way to where it knows how to survive, and it needs to be with its mother. And any time that we as midwives interfere with that precious time, we don't realise what the long-term effects of that are. And you know, we might be seeing the mother at home, but what, for a 10 or 15 minute at the maximum, probably a half an hour appointment, we're not spending time with them. So the benefit for me with being able to have the opportunity to birth at home with women, or the women giving birth at home, should I say, language is very important, the women giving birth at home, was that I learned so much more that I hadn't known before. They taught me so much. So I was able to step back, not do anything unless it was absolutely necessary, but also had the knowledge and skills through my education and my work in the hospital to know what to do if I needed to do something. So it was really important. So over 25 years on roughly 1,000 home births, it was a phenomenal experience. And sometimes my heart aches for it, but I'm too old now.
No, but your path has taken a different route, and And this accidental, as you say, this accidental journey that we're all on now is just equally as impactful and important. And yeah, we're making waves, aren't you? You're making waves. The Thompson Method is reaching many of us, and you're touching our hearts too. So tell me a little bit more about your research then, because as a midwife, you also were quite well known as an expert in the industry and an expert within breastfeeding. You had people from all over coming to you for your guidance on breastfeeding and what your suggestions were. So tell us why your research took a turn on the forceful.
I started off the travelling midwife, right? So I used to travel wide and far for women, and especially if they wanted a midwife and they couldn't find one, I would travel. Even in an aeroplane, I would go. So it's known as the travelling.
Yeah. Dr. Robyn attended her grandson's birth, Josh, who was in Japan. Is that right?
That's right. Yeah. He was born at home, and Kai, the other one, was born in Melbourne at home. Yeah, but I was very privileged, and my niece Emma was born at home. Was born in a birth centre. Yeah, she was born in the birth centre that I set up at this private hospital. So
that's what we have to discuss in another show. That's definitely a story there, I think.
So we're focusing right now on what was the question again? I'm offbeat again.
Oh, so am I. We were talking about how your research delved into the idea of the forceful techniques and why they started. Why did those come about?
Yes. Well, because what I was seeing was so many women coming out of the hospital system. I wanted to know why they were coming out with breastfeeding complications in the region that I was in, and wherever I went, I would see, if I saw women, it was about why was this happening. And so the complications of breastfeeding through my research were nipple trauma being the highest. Then there was mastitis and engorgement, because of engorgement, blocked ducts and mastitis. And one of the most common things is babies were separated from their mothers, or they were handled by other people. So the interruption seemed to add another dilemma to it for the women. And of course, it's a mammal mother's instinct to protect her baby. She wants her baby. She hasn't grown it in those beautiful transitions to have someone take it away, unless it's absolutely.
And speaking of those beautiful transitions, in the very last episode where we discussed the medicalization of birth, we were talking about that connection and the transition between pregnancy, labour and birth, and how the decisions made during pregnancy can impact, and having the education to be able to make informed decisions. And we also looked at some really shocking statistics of the cascade of intervention, as you call it, and how so many women, high percentages, above 40%, are having interventions because of due dates or baby sizes shown on growth scans, which aren't very accurate. And we looked at the many different reasons why a pregnancy may have interventions. And then we looked at how that can impact breastfeeding. So do check out that live episode, because it is very informative. But I guess the key to success, we call it success, but it is within the right for a woman to feed however she chooses to feed. And if that is breastfeeding, being informed on these things can make all the difference.
So the emotional, we have to take into consideration what we're doing to her long-term emotional state when we interfere with her body and we interfere with her baby unnecessarily. I emphasize that, and that a mother has the right to have her baby from the moment of birth without anyone else touching, and midwives who are skilled can actually look at the mother and baby and they can see that the baby's okay. They've already done an APGAR score, and they just keep looking every now and then, and they're watching to see that the baby's continuing to be okay. So there's no need to separate a mother and her baby. No one should take it away. And so by understanding all of those precious things, very precious things, we create an environment for a woman who's now going to go to the next transition of her early postnatal care. She's going on to then raising her toddler, and on it goes and on it goes. And she has the strength and the desire and everything to go with that. But if she's mentally affected by what's happened to her, it can be terrible times for her. And the stories that women are telling me, some of them are absolutely horrific, and they are all recorded. We haven't done anything with them yet, but we're hoping to in the future. Some of them, and I think
that the research that you have conducted, and the research that's coming out very recently since COVID and the increase in home births, is actually that there is a definite and absolute link between birth trauma and postpartum depression and postpartum anxiety. And it is quite obvious that there would be a link, in my opinion, because it is not fair. There are circumstances which are happening which are absolutely considered abuse, and they should not be happening inside of a care practice when you're supposed to be safe.
Behind closed doors. No, they should not. And then the other really important thing is not to touch the baby. If you take a baby by the craniocervical spine, which I studied like you would not believe, to understand what was going on, why babies were behaving that way, why mothers had horrifically damaged nipples. Horrific. It was terrible. Not all of them, but a lot of them did. And so I really wanted to know why. And so the holding of the base of the baby's head where the small brain is and shoving the baby on a breast, that they described while they were holding the mother's breast like a hamburger. I mean, that's just, then they're shoving the baby onto this hamburger. I mean, goodness me, baby cannot use its oral cavity if that happens. It doesn't use its lips. It doesn't use its tongue. It doesn't use its oral vacuum system. It just has a lump of meat shoved in there.
And it definitely happens. I've experienced myself. Most of our team have. We hear stories like this all the time. And it is associated, those first forceful techniques you just mentioned, associated with the cross cradle technique, which of course you have studied in depth, in a lot of depth. So all of these things that we're discussing impact, of course, not just the initial stages of breastfeeding, but we hear of nipple trauma, bleeding, scabbing for weeks, and it's just not necessary. With some really gentle and patient adjustments, it can make a world of difference. It did for me with my firstborn, and I've had no nipple trauma this time with Grace. Thank goodness that I did discover Dr. Robyn herself, but also the Thompson method, the research behind it, understanding how the oral cavity works, and just being gentle with myself, with my baby, with time, which is very precious when you have a newborn. And like Dr. Robyn so eloquently said, it does go into toddlerhood, and whether you continue breastfeeding or not. Many of our members discuss how it's changed and impacted us as parents, just having the right, being given permission, which is bizarre, to just follow our instincts and trust ourselves a little bit more, which is almost ripped from us when we're told, oh, you're doing it wrong. No, you're not giving enough. You should do this, introduce that. It's very overwhelming for us mothers.
Yeah. Now, in that, it was added to the way the mammal baby comes to the breast because of the shape of the face, right? I'm not going to go into detail of that now because it takes quite a long time.
Of course, but you do go into great detail in the online education.
They're all interconnected. Everything from the craniocervical spine to the oral cavity, the function of the oral cavity, to the shape of the baby's face at birth, to everything that's connected there is so important to understand. And then when the mothers actually experience that, including looking at that mother with her unique body, her unique arms, the way she's holding the baby, again, she might be cradling the baby, but it's how she's cradling the baby that's important too. And all the other factors that go with that makes a difference to the woman saying, oh yeah, that feels better. Or, oh, there's no pain. So
yeah, absolutely.
If we understand that, I think it really does need to become part of the understanding of the anatomy, physiology, all that connected with it. I don't think it's far enough. And I was very fortunate to have the encouragement and the guidance to be able to, bring all this out to the public in writing, because back there, I was just doing it to find out for myself why. So it was, and I was very fortunate.
Dr. Robyn's thesis and a lot of her research is available online as well. So do get in touch if you have any questions or if anything has piqued interest. We would love to share those resources with you. And of course, if you are interested in learning more about the Thompson method, then do join our free Facebook community so that you can further familiarise yourself with Dr. Robyn and her methods and learn more about the 3 golden hours, for example, or how those forceful techniques can impact breastfeeding. And there are so many interesting topics that you should be considering during pregnancy so that you can feel more confident and focus on your precious baby.
And I apologise for the boom, 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 because
no,
it's here.
We love it. It's your passion.
Yeah, it is my passion, and I do get excited about it, because for so long now, it's for not for everybody, but for a very high percentage of women who have been able to continue to breastfeed. And I had a message from one today, or I had a story from one today that's so excited that she was told she'd not be able to breastfeed, and she's just breastfed for 18 months.
Yes, that lady who suffered cancer, right? Is that the lady you're referring
Twice
to?
she had a thyroid and a thyroid. I think she had a thyroidectomy and cancer twice.
Yeah.
And she was told she probably would not be able to breastfeed. And bless her soul, she's continued on for 18 months.
Yeah, she has done really. We're all so proud of. We're so proud of you. You know who you are. We have shared your story recently, and what a beautiful photo to accompany Robyn, eh? That lovely, cute photo of mum and baby.
It was adorable. Yeah.
Yeah, we do have so many beautiful success stories. So do take a look at those. And Dr. Robyn really is. She is making waves and touching so many hearts. Her name is a household name now for many of us, because she somehow finds the time to help us all. She somehow finds the time to look at our unique circumstances and sprinkle her magic over our stories.
And I do have a lovely team now which is growing, and that team is helping me right around the world. So there's a beautiful team of people, and there's a beautiful team of lead practitioners as well, who are able to work with women, and they've spent a lot of time with me too. So it's not just that they've started it, they've spent lots of hours with me. So I think, if we can do more of that, and we can be gentle, and we can be calm, and we can be encouraging, and we can not tell women what they have to do, how they have to do it, when they have to do it. It's not part of the deal.
No, well, it shouldn't be. Unfortunately, for many, it is, and that's why this is important. That's why reaching out is so.
We want them to have confidence in themselves, and yes, they need help. We'll certainly be able to help them, but it's this fear all the time that's being generated.
Yeah, for sure. Yeah, so lactationization, take away from that, like Dr. Robyn always says, it's your body, your baby, and policies and procedures are not legislation. They are not law, and you can say no. And I think with that is the best note. Did you have any last words, Dr. Robyn?
No, I think I've done the pressure bit. I think I feel like,
I think we like to get that passion going, don't we?
Well, I do get excited, because
of course you do.
I feel in here, sometimes I cry with the women, and I cry with them, especially if they've been treated badly. But in here, this is ticking away, and then suddenly it's
when it's your life's work, and
when I'm sharing. Yeah, when I'm sharing,
yeah.
But I've got a lot of people to thank for leading me on this pathway. Yeah, and I think I might have done that before. Have I, with my professors? They, oh my goodness, I owe them the world.
Well, and we owe you ours, so thank you. And I'm sure you'll all have noticed the passion coming through there, the hold back of tears that we just see. And Dr. Robyn is always sacrificing her time, her education, her resources, her brain, and her respect of always is given up so freely. So thank you so much, Dr. Robyn, for your time today, for your time always, and for helping us break down this very interesting and controversial topic, lactationization. So let us know if you have any questions.
That's part of the big model. It's one part of the big model. Yes.
Which is the ization syndrome. Broken down into 4 parts, but many parts really.
Well, I think there's more parts added now.
For sure. Insuranceization.
Yeah, that's one. Yeah. And technicalization's coming soon too.
Yeah, for sure. We will add to it. Thank you so much. And to our viewers, thank you so much, and enjoy the rest of your day.
You too. You take care. It's my night. It's your day.
Yes, for sure. Thank you for everyone watching all around the world as well.
Thank you very much. Thank you.